It looks like it is 8 o'clock Eastern time. And so I think we are ready to get started. Is that right, Nathaniel?
That's correct, Yvette. Floor is yours.
I want to welcome everyone to this special week. This Bloodless Medicine and Surgery Week 2023 is going by very, very fast. It's very special because we think about everything that Dr. Cooley did many decades ago, and also our present pioneers. We want to raise awareness about bloodless medicine and surgery. It is a superior form of healthcare. And as one of my first medical directors said, who is a blood banker, it is simply better medicine. We want to thank our organizers. This is organized by the Bloodless Medicine and Surgical Group in University of Calabar in collaboration with the Bloodless Medicine and Surgical Society. It is also being live streamed on YouTube, so you could go to the BMSS YouTube site, Bravo Mary Sierra Sierra, and the Society for the Advancement of Blood Management, which I'm a founding member. They have been a huge contributor now for 2 decades. I am monitoring this, and please excuse me when I butcher your name. I am linguistically challenged, coming from a bilingual home. So we have moderators, Shunji Kawamoto, Dr. Kawamoto, Dr. Shaneshe Obekwe, and myself, Yvette Bunch. Our keynote address is Bloodless Medicine and Surgery. Oh, I should turn this over to our moderator before we do this for some housekeeping. Can you do that, please?
Oh, thank you very much, Liberty. And yes, we are very happy having you all, and we all welcome to attend this educational and informative meeting, Bloodless Medicine and Surgery Week 2023. And in fact, we had a poll on Monday that shows this webinar is being attended by participants from all continents of the world except Antarctica. The program here today, we will have 3 seasoned clinicians and international speakers, and also we have panelists, many panelists, and so we can expect them to give a comment in the Q&A session. And so let's get started today's meeting. And in first place, there was some housekeeping, and all questions should be pressed in Q&A. And you can, if you have some question, you can post the Q&A link. And you might want to click the mute button during the speaker's talk, so as not to distract other attendees and the speakers. And so this program is being streamed live on BMSS YouTube channel, in the case someone has difficulty with Zoom. And so you make notice the YouTube link in the chat, or in your YouTube search, you can type Bloodless Medicine and Surgery Society so that you can see this live session in the YouTube. And so that's all. Is there anything housekeeping? That's all.
I think that you did an excellent job, and I neglected to say that Dr. Kawamoto is a professor of surgery from Japan and a director of a bloodless program. And so it truly is a worldwide audience, and we wish to thank you. Our first speaker, our keynote speaker, is Dr. Anantha Krishnamurthy. She is a medical doctor with diverse experience in rehabilitation medicine, primary care, and occupational health. She is certified by the Society for the Advancement of Patient Blood Management, or SABM, on the fundamental and advanced concepts of patient blood management. She has a varied career, including stints at the Blood Management Center in the United States at St. Luke's Hospital in Kansas City, the Center for Bloodless Medicine and Surgery in Penn Medicine, University of Philadelphia, Pennsylvania in the United States. She also is a published author in the medical journal Malaysia. So again, we're going around the world. and is a collaborator for the manuscript, A Global Definition of Patient Blood Management. And this was published in the prestigious Journal of Anesthesia in February 2022. She has been actively involved in organizing patient blood management conferences in Asia, which is so important. Again, being a diverse audience and getting this word out. And she seeks to promote the superiority of patient blood management, bloodless medicine to everyone. She's also a past secretary of the Malaysian Society for the Patient Blood Management and the current secretary of the Bloodless Medicine and Surgical Society. So I would say you do not have any grass growing underneath your feet. You are a very busy lady. So now we're going to go to Malaysia to hear this keynote address, Bloodless Medicine and Surgery, the bridge to recovering what is lost.
Thank you very much, Yvette, and also Dr. Kawamoto and everyone in BMSS and everyone here for giving me the opportunity to present. So it's been a wonderful time together learning, and I appreciate giving some experience from what I have also learned. Yeah, so let me share my screen. Just a moment. Okay, is this okay? Okay, all right, yeah, good. Thank you. So today I will be presenting on bloodless medicine and surgery, the bridge to recovering what is lost. So we're just going to see some outline and see what it's all about, right? So the outline is what is actually lost and what are the lessons that we can gain from the pioneer and what was actually recovered and what is the future direction. Okay, so we're going to learn actually from a lesson from a real life example. You know, they always say that our patients are the best book in that sense. So we can learn a lot from our patients. So this is one young lady. She's a 26-year-old. And in October 2018, she presented with lethargy and decreased effort tolerance for 6 months. She was actually seen in the medical clinic. Upon further questioning, they noted that she had irregular menses and also menorrhagia. But I think previously she was on oral hematinics and she was not able to comply to it. I guess a lot of people would know it's not easy to be compliant to oral hematinics. Her hemoglobin at that time was 7.3. And the T-set, transferrin saturation, was 3%. So just looking at these two levels, we know that it indicates iron deficiency anemia. However, in this case, they did do quite a number of extensive tests, including like, full blood picture and others, you know, even to the point of considering HB analysis. But yeah, actually, when we just consider this history, we can actually come to the conclusion that she actually had iron deficiency anemia. It's interesting to note of the options of treatment that was offered to her. In this case, it was a chronic stable anemia, and this patient was offered a blood transfusion. And since she wasn't keen, then the other option that was offered to her was oral hematinics. So that was at that time. And in later couple of years' time, of course, in between, she did have some blood tests done. As we can see in the graph, in July 2019, interestingly, her hemoglobin had gone up to 15. Likely at that time, her menses were a bit better controlled, and also that she might have been better, having a better diet. and also probably is really compliant to oral hematinics. It's quite interesting. So, however, the ferritin test around like when her HB was 15 or 13, her ferritin levels were actually very low. I did not include it here, but it was actually below 10. So that is an interesting point to note. In December 2020, she actually had menorrhagia for 3 weeks. And she again presented with lethargy and dizziness and decreased effort tolerance. Now, this is considering 3 weeks of menorrhagia. And look at what has happened to her hemoglobin. At this time is 5.6. And the MCV at that time is 68. And this young lady, she was actually able to walk around, and she has been at home. And the main indication that she was actually told to have the urgency of transfusion was that, yes, one is her HB is below the trigger, the usual trigger that we all hear about. And the other thing was that she was feeling lethargic and decreased effort tolerance. So the reason that she was told that she needs a transfusion is that there might be a risk of cardiovascular compromise. So we need to look at that again, right? Yeah. So anyway, in this case, this patient was not a bloodless patient. And so she did listen to her clinicians and she was given transfusion. And subsequently, she was also discharged with oral hematinics. And she was also given OCP, oral contraceptive pills. Now, if we look at the graph again, we can see that the hemoglobin progression, she was discharged with a HB of around 10. That was like 1 or 2 days after transfusion. And so after that, a few months later, and even up to 10 months later, her hemoglobin is still around 10, right? So again, we can see that this is not really an optimal treatment. And this is something that we can learn, that she has actually lost something, right? So what are the aspects that has been lost when we actually see treatment in this kind of case? So we need to see, right? Actually, in few areas, actually each area we actually lose something if we did not practice bloodless medicine and surgery, right? So in the medical field, when a bloodless medicine is not practiced, in that sense, because the medical field finds that blood is easily replaceable, right, with something from an external blood bag, right? So in that sense, the true value of the blood that is in the patient is actually lost, right? So this is something that is lost. As for the healthcare professional, what actually do they lose? It's interesting because when we know that there's something that is so easily available that I can replace easily, if I need to conduct a surgery, I know that I can hang on in case there is excessive bleed. I can still transfuse the patient. So I do not need to perfect my skills for a meticulous surgery. In that sense, I will lose, right? So, and then if I know that there is this blood is easily replaceable, then I do not improve on my adaptability or teamwork. So these are skills that is actually lost. As for the patient and the family, because they are not given much options, right? It's either transfusion or no treatment, or it's just oral iron, right? So the thing is, the tendency for the current practice is that to have a paternalistic kind of behavior. And so in that sense, the patient empowerment or the right to choose, make an informed choice is actually lost. We will learn about it later. I believe Cassandra will be presenting on that. Yeah. And as for the patient also, because the health is now not optimized, as we can see in the patient, the hemoglobin was just, it did not reach to optimal levels. Transfusion, it just probably gives a temporary relief, or, it's kind of probably a relief to the clinician. However, it does not really produce a lasting and sustainable result. And so in this case, this patient is actually having her health and productivity affected. As we can see, she did come to emergency a couple of times after. I think in that case, she had symptoms of palpitation or, hyperventilation. So we do not know whether does that have anything to do with her iron deficiency or anemia, right? So in that sense, she actually loses her optimal health. She loses her productivity. As for the community, what do they lose, right? So if we do not treat our patients optimally, then our population health is actually suffers, right? So generally, the patients that we treat are not optimal. They're not really healthy. And so that will actually also affect the economic prosperity. So there's actually a lot to lose if we did not really value or put the value in the right place, right? So just looking at this picture, you want to see which is actually more valuable, the image or the real substance. Well, we can see the mountain, right? And we see the image, right? But again, we remember the image is just an image, right? So we need to think of where is the right, which is more valuable, whether the blood that is in the patient or the blood that is in the blood bag, right? Okay, so let's see more. So again, in this patient, right, so her health is suboptimal, so she can undergo like mental and physical health problems. And that again, as we know, anemia increases morbidity. Her quality of life, symptoms of iron deficiency and anemia will definitely affect participation in daily activities and social life. So, this is a nice table or nice kind of the journey of ferritin, right? So we see, I actually got this reference from ironsweets.com. So they have a clinic in Singapore. So, but it's very interesting to see with the dropping of ferritin levels, there is a lot of symptoms that we actually undergo. And so in a person which has anemia, by that time, the ferritin is already depleted. And we can think of all the symptoms that a patient or a person would actually undergo. Like we think hair loss is normal in females, but it's actually not normal. Yeah, and fatigue, we can't really say that a lot of us feel fatigue, but whether is it really due to iron deficiency? And so all of this will actually limit our daily activities as well as limit the social life in a young person or even right to someone who is much older. And definitely work performance and productivity is also affected. So again, plenty is lost if we did not really optimally treat the patient. And again, we're talking about population, right? So this is a WHO document. This was the policy brief from the World Health Organization. And so here it mentions that 1.95 to 2.36 billion people are estimated they're actually having anemia, and more than 1.2 to 1.4 are also iron deficient. So think of that one patient with all the symptoms that she has and multiply that with 3 billion, right? So it's just one person that we actually see with all those symptoms and all those effects, because we do not see everyone all together at one go, but we're looking at now the breadth and also the depth of the problem. So it's really a huge loss if this condition is not properly addressed. Again, this is a study done among Swiss women. So they have mentioned about the economic burden of symptomatic iron deficiency. The unfortunate thing is a lot of these women, they are actually iron deficient. However, they are misdiagnosed as having depression, burnout, anxiety, say chronic fatigue, right? So these are all symptoms can be attributed to iron deficiency. However, because they are misdiagnosed, and so they get treatment for something that is not appropriate. And so again, there's a lot of cost and burden. Also, we see that a lot of them usually say that they are exhausted, right? And have sleep disorders, depressed. Yeah, so there's plenty of negative things, right, that we see. So again, we can think about the sheer scope of this problem. Right, now this was something just done locally in the hospital that I work in. Just because I work in the occupational safety and health, I just come across certain staff who have some symptoms. And so we did look at the ferritin test done across 2 months. And I took a sample of 15 people. And it's interesting, out of 15 people, 14 had suboptimal ferritin levels, right? So if we want to say iron deficiency, we have 12 people actually having iron deficiency, 12 out of 15 out of, the ferritin test that we did. So it really seems that plenty of people are actually having this problem. Now, here again, the question comes about, does absence of anemia exclude iron deficiency? We always say that, okay, if the HB is normal, then it's fine. In the same group of people, we see that even those with HB of 13, 14, 12, the ferritin levels are low. So actually, even all these people are actually still having a lot of symptoms and burden in their lives daily, right? So again, these are among the things that is lost. Okay, so we've heard a lot of things that is lost, right? Now we look at what can we learn from a pioneer, right? Yvette was also just mentioning about this special person, Dr. Denton Cooley. And so, yes, definitely he is the pioneer for bloodless medicine and surgery. And the thing is, I just came across this LinkedIn post by Texas Heart Institute. It's quite interesting. So yes, they do recognize that he is the one who actually contributed to the development of bloodless surgery. And that was in 1962. And hence, again, is a Bloodless Surgery Day is actually commemorated on May 16. And yeah, so this week is the one that we actually celebrate or remember as a Bloodless Medicine and Surgery Week. And here we are learning about this superior medicine. So Dr. Denton Cooley was known for being versatile, and he's a masterful surgeon. And he was responsible for numerous discoveries in the surgical and cardiothoracic field. And in May 1962, he performed the world's first bloodless open heart surgery on a Jehovah's Witness. And we know that for a Jehovah's Witness, blood is not an option. And within a year, he did 6 more cases. And for many years, he was the only surgeon who was willing to operate on this group of patients. So in this case, here we see the start of bloodless medicine and surgery. And it's interesting that it is actually started by someone who is very notable, charismatic, and very masterful person, right? So we will learn more. This is actually a newspaper cutting. I just found it also today. It's in 1977, San Antonio Star. So it mentions about top doctors performing heart surgery, right, without blood transfusion. And some of the points that I found interesting, I think even in 1977, there's a doctor called Dr. Kenneth Riegel. He actually mentioned this point, that blood is more uniquely individual than a fingerprint, and it is like an organ transplant. So this is something that we all echo now, right? And yeah, 1977, that was when he mentioned that. And I believe it is something that we really need to keep in mind again, the way that we really think of blood, and to really treat it with respect that it deserves, right? And again, cardiovascular operations can be performed safely without blood transfusion. This was from the study from Dr. David Ott and Dr. Denton Cooley. Right, here they actually presented 500 over cases, right? Jehovah's Witnesses, successful open heart surgeries. And this is about 20 years of experience. talking about consecutive series of 542 Jehovah's Witness patients. And look at the age range, 1 day to 89 years. So if they can do it then in 1977, we have to think, is there an excuse not to do it today? Right? So if we can learn very much from these great pioneers, then definitely we can actually improve as well. So what are the qualities that Dr. Denton Cooley has, right? Amazing qualities. One of it is he was actually curious and he's actually having a progressive mind. So at that time, he was faced with an obstacle, I believe. In that time, it was mentioned that it was difficult to look for blood to be part of the prime in open heart surgery. And so they had to look for non-blood prime because there was a shortage of blood. And also there was an issue about safety. Hence, that is why he and his colleague, Dr. David Ott, actually, they both worked together and pursued this work of producing non-blood prime. So in this case, it's also interesting to think of the lesson that sometimes we actually face now. Even locally, we have shortage of blood. And so what happens is when there's a shortage of blood for transfusion, what goes more is actually blood donation drive to actually ask people to donate more, right? But if we can start to think like Dr. Denton Cooley, if we know there is issue with shortage, there is issue with safety, are we able to do something else which provides better outcome and reduces cost, just like what he did, right? Instead of asking for more donation, right? The other thing that he has is skillful hands. We know that he's very good with his hands and he operates very quick and he has less blood loss, right? So that, of course, provides for successful bloodless surgery. And he has also empathetic and willing heart. So he is actually moved to respect patient wishes and he wants to help people. And so he is willing to go beyond what is needed at times to actually do what the patient needs, right? So these are definitely a combination of very beautiful qualities. So he's a pioneer of bloodless medicine and surgery, and we see many of replicas, right, among all of you here. And so we see that many of the ones here have helped so many people, just like what Dr. Denton Cooley has done, right? Okay, so now we go back to, since we have learned now what is lost, and we learn from the example of the pioneer, we can see the contrast from another patient with similar problems. This patient is actually a 20-year-old. She didn't have any comorbidities. She also presented with menorrhagia. Her hemoglobin was 6, and then it dropped to 4.9, and the lowest was 3.6. And in this case, this patient did not receive any blood transfusion because in this patient, blood was not an option for her. And what is the difference, right? In this case, just like how when faced with obstacles, we are able to overcome it because we know that the other road is already closed, right? So we don't say it's the total roadblock. But in this case, yes, this patient received intravenous iron. She received tranexamic acid to control the bleeding as well as oral contraceptive pill. And at the time when her hemoglobin was low, she was also supported with supplemental oxygen. She was asked for bed rest and also protected with the proton pump inhibitor for her gastric to prevent any gastric bleeding. So look at the evolution of her hemoglobin. We noticed that it dropped right to 3.6, so that was the lowest. And at that time, we did not have high dose iron, so we gave her this another iron, which is iron sucrose. And so we noticed that her hemoglobin continued to rise right? And it was actually sustained even up to 1 year later, right? So this is a contrast as to what the other patient had. So sometimes we always hear clinicians may say that if you do not have blood transfusion, you will die. Yeah, in this case, the one who had a blood transfusion did not receive optimal health outcomes, and the one who did not receive a transfusion, the one who did not receive a transfusion gets better health outcome as compared to the one who got a transfusion. She did not get an optimal outcome. So it really debunks the myths or the kind of hearsay that we hear, right? And so we again have to look at evidence. And I believe many others have also presented similar things, that we have seen that patients who are having bloodless medicine and surgery treatment, they actually do better, and they actually have long and sustained good results. Okay, so whatever that was lost earlier is actually recovered in this case, right? So we see the true value of blood. So the patient, actually in this case, because the patient does not accept an allogenic blood transfusion, so they really have to value her own blood. And so they did not have any much of blood taking in this patient as well. So phlebotomy loss is actually minimal. And then they try to optimize her own blood. So in this case, her own blood was actually valuable. And in this case too, the doctors who are treating her actually learned to adapt better, and they had to have a lot of teamwork. They have to work with ONG hematologists. Yeah, and so they did actually have good teamwork. And in this patient, she did have her right to choose, and it did give her better outcome and improved productivity. Right, again, we're coming to the point of which is more valuable. Again, we see that with bloodless medicine and surgery, then the focus is on the right area. Okay, so what is the future direction? The WHO actually did have a document on anemia, and there was a caption that they mentioned. It says that it is estimated that for every US $1 that is invested in reducing anemia in women, US $12 in economic returns could potentially be produced. So isn't that interesting? With very little that we actually put in, by really valuing the blood that is in the patient, improving anemia, treating it optimally, then we can get 12 times of what we actually put in, right? Yeah, so we need to really, again, our future direction. Actually, it has already happened in the past with Dr. Denton Cooley, right? So we need to reestablish and remember that and continue on, right? To recognize the true value of blood. The blood that is, as what a lot of us have heard, the blood that is in the patient is the one that is most valuable. So we want to cherish and protect and implement strategies that promote blood health. So this is a point that also many of you are also promoting and championing, as well as I believe in the book Blood Works, right? So we can learn a lot about blood health. Yeah, so this is actually the future, right? And bloodless medicine and surgery should be a standard, not just limited to a certain group of people, because we know the benefits are actually really good for all. And so it should be standard so that everyone can actually benefit from good health and superior knowledge and skills. Okay, that's it for now. I'd like to acknowledge everyone who have contributed to my growth. Thank you very much.
Thank you very much, Ananti, for your nice and excellent talk. Yes, we have noticed how there's a very clear contrast between two different treatment. One is treatment that we consider the default, in this case, the failure to act, the doing the necessary treatment. The other is the treatment by the bloodless medicine that, yes, we ran the beneficial real fruits from the necessary treatment. And we also noted that how productive and productive treatment for not only the patient, for the society as a whole. Thank you very much. And now let me introduce the next speaker. The next speaker is Nurse Cassandra Upchurch. And Nurse Cassandra Upchurch, she's a Master of Science in Nursing and registered nurse and a legal nurse consultant. And she became a registered nurse in 2007 after attending the Westchester University. She started her first registered nurse role at the University of Pennsylvania Hospital in the trauma surgery and surgical ICU. And after being in this role for some time, she continued into the additional nursing experience, including critical care, acute care, and home health and hospice care, and managed care and long-term care, and leadership and nursing administration, and bloodless medicine and nursing education, and patient blood management, and legal nurse consulting, and infection preventionist, and transplant coordinator, and travel nurse. And Cassandra completed her Master of Science in Nursing Administration from LaSalle University in 2021. And she's the owner and lead instructor of First Aid and CPR Academy LLC and ANITA Critical Consulting LLC and Quality Caring Professionals Training Center LLC. She also functions as an adjunct professional at Widener University Nursing Program. And Cassandra has published multiple articles in medical and nursing journals. She has presented at national and international conferences related to bloodless medicine, business, and patient care delivery. She's a writer, course developer for NETCE, and subject matter experts writer for GW, and clinical director for Tender Care Hospice LLC. And her topic, the theme of her topic in his talk is nursing and advanced derivatives in bloodless medicine. So we can hear her words as from the, I think, a multiple dimension. And so, Cassandra Upchurch, you have our attention.
Okay, thank you so much. I'll share my screen. Okay, I was worried that wouldn't work. Okay. Hello, everyone. Thank you for having me today. Thank you for being on. Today is a very important, or the entire week is a very important conference. So I know I've benefited greatly from hearing all the great information from all the speakers, everything we've learned. So it's definitely beneficial to have this exchange of knowledge, but also to be able to educate the community and those that may not be working in the bloodless medicine environment regarding the importance of bloodless medicine as a discipline. So I'm going to talk about nursing and advanced directives in bloodless medicine. And this talk is really to complement everything we've been learning so far, that there's a lot of medical and surgical techniques, but there's a large component where, again, as always with healthcare, the patient is the focus and center of our care delivery. So we want to make sure that we always have a way to be able to empower them so that they can make an informed decision. And bloodless medicine definitely allows nursing to be a huge contributor and collaborate in building that framework that makes a bloodless medicine to help drive that autonomy and individualized care for our patients. So we'll talk about that somewhat and the role of the nurse in that respect. So we're going to talk about the impact of nursing, implementation of the process of bloodless medicine, and advanced directives. So just a snippet about nursing as far as it contributes to the healthcare field. Again, the focus on this is on the nursing discipline specifically as part of the interdisciplinary team. So we do know that nurses are and specifically make up the largest healthcare profession. So in the United States alone, we have 4.8 million RNs. And that's just licensed nurses that are RNs. That's not including all the other disciplines that fall under the umbrella of nursing as well. So definitely a huge profession, which means that that kind of reach makes it very impactful. So there's a lot that can be done on behalf of our patients when we have that kind of outreach as a team. One of the other things we want to consider is that nurses have also been one of the top rated professions with the Gallup poll as far as top ethic ratings. And so we all know that when it comes to ethics and being noted by patients as one of the most trusted professions, it means just that it makes it a lot easier and a lot more, and makes it possible to build strong relationships with patients. One thing that we do know is that there's always a barrier in healthcare and a delay in decision making and misunderstanding when a relationship and trust is not established because the relationship is not strong. And so this definitely impacts the patient and their ability to make an informed decision. So again, that definitely has a lot of impact as far as bloodless medicine and healthcare overall. And we're also going to talk about the diversity in nursing roles. Nursing typically, like most other disciplines, exists in pretty much every area of healthcare. So we'll look and see what those areas are as it relates to bloodless medicine and surgery. So nurses' role in healthcare as it relates to nursing in the United States. So we have some very specific roles that are in the acute area and some outpatient areas as well. So you'll find nurses in these roles at the bedside, nurse leadership, your advanced practice providers being your CRNAs, your CRNPs, your CNS, your quality assurance individuals. They have roles in the OR, your coordinators, and the bloodless medicine program, in addition to your managers and directors. That's a part of leadership, and your nurse educators. All these roles are very important because that means that this is extended reach that we do have. These are additional opportunities for impact that we do have. And so this education that develops from the core in bloodless medicine, we can use those channels to help reach patients, to help reach the community as well, but also to change practice too, because of course, everything starts with research, and that's how we put that into practice. And so we want to keep that in mind when we understand that the strategies, everything that we do from a medical, surgical, or clinical standpoint, absolutely has a reach in other areas as well as it relates to nursing. So we'll talk about that as well, as far as those pieces that build up the framework that really helps us to do what we do as healthcare providers, because we know that bloodless medicine is not just a discipline or strategies that will exist or is impactful just in the hospital encounter or during surgery, but also it starts before the patient is even in the hospital and it continues even after their discharge. So especially for our bloodless medicine patients, it definitely has a lifelong impact. And so although management will always be a part of the process, maintenance is very much part of the process. And so we'll look and see how that's done. So of course, we know all these important factors about bloodless medicine and surgery programs, that patients who are in these programs are refusing red blood cells, white blood cells, platelets, and plasma, that it allows individual decision-making, that there's alternative strategies or, enhanced strategies really for clinical management for patients, because as we've learned, especially on these conferences, that patients who are not transfused, they actually do better clinically. So again, it's an optimal healthcare outcome, but also that these programs are developed to facilitate that process, to kind of build that connection between understanding and practice. And so one of the things we want to consider is, we may know all these things about the importance of the program. We may know all these things about the impact of anemia and blood loss, but how much does our patient know? Regardless of how much we understand, how much do they understand, and how much have they been informed about their options? So again, benefits of bloodless medicine and surgery, but how are we communicating this to our patients? So again, are we giving them the information and developing tools and strategies and education and resources for them to choose the better option? We know it's a better option. We know it's a safer option, but in what ways that communicated to them? And again, what resources do we provide to get them to that point where they know how to make this decision, that they don't want blood, that they understand the benefits of a bloodless medicine program as well. We do know that patient blood management is definitely strategies that extends to every patient, because again, we should implement these very beneficial strategies to everyone. And bloodless medicine is more of a specialty for patients who under no circumstances will accept blood products or blood transfusions. But again, how much do they understand about the actual programs, besides the fact that a majority of patients who enroll in the bloodless medicine program, a huge driver for some patients is religion. And then you have a smaller percentage that will know a little bit more on the clinical side and they refuse because they know the implications as far as outcome. But again, it has a huge, a larger effect for the overall population. So again, we need to make sure that that's understood across the board. So as nurses, a big part of the framework that we contribute to building is that the nurse is a big part of the primary assessment. So in a lot of cases, when a patient starts to become hemodynamically unstable, or a patient, again, is not fully aware of what options they have, or their labs or maybe their past medical history has a huge impact on how a procedure may go, and considering the best approach for this patient. That pre-assessment, in most cases, the nurse is a big part of the front lines, a big part of being a gatekeeper. And so when that patient starts to really deviate from what we consider normal or optimal, your nurse is going to be a big part, especially your bedside nurse.
I think she needs to go out.
Can you see my screen?
Yes.
Okay. It's really a big part of identifying these changes sooner than later, because we all know that early identification leads to early intervention. And so how do we, again, keep close eyes on monitoring this patient and picking up on even the subtle changes, even a change in their vital signs, a small change in their labs when there's a change in the pattern, or even a change in the patient's neurological status, which are early indicators of a patient decompensating. So with that being said, that's assessed early on, that's communicated across the healthcare team in order to allow all disciplines to really intervene sooner than later. But even prior to the hospital admission, the evaluation that goes into place, again, educating the patient so they're aware of what their options are, how to manage how to prevent anemia, how to manage anemia, and also those strategies they need to implement even when they're home. So again, we want to keep in mind that the nursing role, even in bloodless medicine, even in the hospital, has a huge is hugely impacted by the nurse being involved in the primary assessment and also early intervention as well. So again, we know the impact of anemia in hospitalized patients. We know the negative outcomes. We know that we want to avoid a blood transfusion. But again, as I always say, is how much does the patient know? How aware are they? We know in the community, we hear patients all the time discuss, hey, I think I may be anemic. And they don't think it's a huge deal. You hear them say things surfacely like, hey, I'm eating ice chips today. I'm always cold. I think I may be anemic. And they don't think that it's a huge deal. But we as clinicians know that it is. So again, that driver, that impact in making sure that the community is educated as far as what anemia is, how it affects them as a patient should they ever become a patient, but also how it contributes to them even becoming a patient in some cases. So even in everyday life, what are some measures that patients can take to, again, stay in the loop and engage with their providers in advance to have those necessary labs and preventive care done to avoid being in anemia and being monitored on a regular basis. But also, what are some strategies they can implement even at home on a daily basis, vitamins, certain routines that they can do at home to even prevent anemia or even identify it early. So anemia evaluation and planning, again, hugely driven by healthcare providers, but again, your nurses being at the front line. So in many cases, even when it comes to your anemia clinics or patients that are coming in outpatient offices for PCP visits, and your patients that are in the hospital for pre-admission testing before surgery. These are labs that, again, your nurses are going to draw, your nurses are going to send those labs off. They're typically going to see them first. And when they see anything that's abnormal, they're going to report that to one of the advanced practice providers for an intervention. And as brought out in some of the previous presentations earlier this week, we know these strategies and we don't want to just do enough to get them through it. But again, we want to be meticulous in how we do what we do. So again, the nurse, drawing those labs, how much are we drawing? How are we sticking the patient to get that blood? We want to keep that in mind. Again, when we talk about in nursing, when I became a nurse in 2007, it was a whole thing where if a patient had a central line, we would draw waste first, and then we would draw blood. So we really want to consider what techniques are being used when even these strategies such as phlebotomy are being done, when invasive techniques are being done for these patients as well. But again, the nurse is a huge part in those strategies that really could help optimize a patient's outcome by evaluating early, assessing early, but also performing any invasive techniques and preventive techniques to enhance the patient's outcome. So again, we also about continuity of care, because again, healthcare or overall health is a cycle. So again, there are all these components to it. So we always have the surgical and medical components that are crucial, right, for a patient, especially when they're already in that phase of crisis. But then there's all these pieces that have to happen beforehand, because we want to make sure that our patients, again, that they're informed, that they have the education that they need to make an informed decision. So are they aware of their options? Are they aware of the risk? Are they aware of the benefits? And so really should be a care team discussion. And in many cases, and healthcare providers, we're definitely doing better with this, but there's this huge gap in literacy, understanding healthcare education. And so what we're learning is that even where we're simplifying conversation and not using heavy medical jargon, and really trying to use certain analogies and education to bridge that gap and knowledge with the family members and patients. We also want to do a good job evaluating how much they understand. And when we get an understanding of where they are, we want to meet them where they are. So again, really determining from an individualized standpoint how much they understand, what we need to do to mitigate that gap to meet that person where they are. And again, that differs from person to person. And we'll talk about some additional tools that some programs use to, again, make sure the patient has the information that they need to make this decision. Some of the things that I'll go into place to make sure that we are able to communicate those decisions are the consent forms that we do with patients, which also helps us to produce digital and physical identifiers to identify that patient as refusing blood products or blood transfusions. But again, all of this happens once the patient is educated enough to be aware of their options, but also to execute things like an advanced directive that we'll talk about shortly. So again, it should always be a collaborative effort across the healthcare teams, where the bloodless medicine team and all disciplines really becomes a part of their care. So again, nursing being a crucial or core part of that medical team to ensure that that is there. So we do know as providers that trust is a factor, that a lot of patients won't even listen to certain, won't even have certain conversations or make certain decisions because the trust factor is an issue. But we do know that there are disciplines that patients may view as dependable and trustworthy as well. We want to make sure that that's a huge part of the implementation and plan of care piece. And so having that trust factor and that relationship and that rapport really does help to, again, meet a patient where they are, kind of help them understand the benefits, but also help to execute those tools that will help the patient make decisions that are best for them and healthier for them, but also to communicate to us exactly what they do want so that there's no discrepancy or confusion about their decisions for their health care. So one of the things that, just go back some. One of the things that I want to highlight is that not too many individuals that are not healthcare providers give a lot of thought to, if I can no longer speak for myself, who speaks for me, who makes these medical decisions for me. And in some cases, people may have in their head a decision maker as far as who that person should be. But the reality is, if it's not executed in a legal document, there are certain state laws that dictates who does get to make that decision. And so for the state of Pennsylvania, this is the hierarchy of the healthcare decision maker in the case that a person does not execute legal documents like an advance directive. So in the case that there are no forms, it defaults to the person's spouse. If that's not an option, then their adult children, and then the parents, adult brothers and sisters, grandchildren, and so forth. So that's something to keep in mind, because we want patients to know that if you don't make a decision about your health care, the state will, so we definitely want to empower them by making them aware that it's very important that they have an advance directive, especially for our bloodless medicine patients, because sometimes the reasoning behind opting not to take blood is an ethical decision for a lot of our patients. But that doesn't mean that their family members are those ones that may fall in this hierarchy as a decision maker should they not execute an advance directive. Doesn't mean that they will respect that decision or even have the same belief system or would agree, especially if the person's life was at risk and they didn't understand all that entailed. So I'm just going to go this way first. Okay, so for our Jehovah's Witness patients, typically, of course, they have the no blood card, this advance directive, which is very helpful in deciding what that person wants done in their behalf should they no longer be able to speak for themselves, as well as identifying a healthcare agent and an alternative healthcare agent, and that's very helpful. But when we get to our programs, and every program is very different in what kind of form they execute, but you want to have a hospital, or we have a hospital specific form that speaks to who they want to identify as a healthcare agent, what they are refusing, specifically for our bloodless patients, those red blood cells, platelets, plasma, white blood cells, but also a checklist that accompanies it to identify which derivatives they may be open to accepting. But also that form ensures that there's an education piece, that they understand what they're signing. So this form allows us to get information to determine what they do and don't want, but also allows the patient to see what their options are and make an informed decision, because there's an education piece in there as well. So they're not just signing a contract that really speaks above what they may understand if they're not a clinician. And this advance directive should be accompanied, as we all know, by a detailed conversation and education by our bloodless medicine and surgery team while the patient is completing this. So some of the tools that can be developed as a result, one second. Some of the tools that can be developed as a result of having that conversation to provide an education are really quick fact sheets. Patients are really good about having certain conversations, but we do know, like with anyone, especially if it's not their specialty, people will walk away from that conversation, and as time progresses, either that's archived information and they don't remember the details or don't remember the rationale behind what was just discussed. And they definitely may walk away with their own interpretation of the conversation, especially if they're talking to additional individuals, because that's what we do sometimes. We go to an appointment and then we go home and we talk to someone close to us, maybe a spouse, maybe another family member, and we reiterate exactly what happened in that conversation, but it doesn't sound the same. It's not the same information because it may not fully be understood. And so again, it's really important because we always want to make sure that patients are able to walk away, whether they're enrolled in a program or not, or just have access to an educational tool that provides detail as far as what their options are in a very concise but detailed way, so they can get to the fact of the matter. But also, most importantly, for our programs, how to utilize the program. We know a bloodless program exists, but what are the steps to be enrolled? What are the steps to get more information? What are the steps to be followed as a patient to make sure that I have an advocate to ensure that my wishes are absolutely carried out and that we can have this ongoing communication. And so that framework with other disciplines and nursing being involved helps to produce educational tools and resources that really help contribute to the framework of a bloodless medicine program, but a patient being informed enough to execute an advance directive and understanding that if they don't make a decision for themselves, a decision will be made for them if they do not, even from a legal standpoint. Also, again, as everybody who has a bloodless program knows, this also helps to develop other identifiers, these physical identifiers that we talk about, that helps to enforce to the healthcare team that this is a patient that's refusing blood products. So in summary, and this was one that most of them look the same. This is one that we did for Lincoln All Hospital when we were building that program. And then we have the patient arm bracelet that accompanies the regular patient bracelet for patients that enter the hospital, and stickers for their chart as well, like most bloodless medicine programs have as well. And so in summary, we just want to highlight that all disciplines are necessary to have a successful bloodless program. And we just wanted to take the time today to really emphasize the importance of the role of the nurse in the bloodless program as a driver and developing these programs and really enforcing the strategies, but most importantly, that communication and relationship with the community and patients so that they can make an informed decision and feel empowered about their decision. The bloodless medicine program is important in facilitating all these pieces because we know education, again, helps facilitate decision making, research, workflow, and processes. So it really impacts how we do what we do and why we do it, and also to achieve optimal outcomes for our patients and continuity of care as well. Just a few references, and that is it. Thank you so much.
Thank you so much. It's always good to hear from you. We, Spartanburg Regional Healthcare System, a program that I helped to develop, we received a Duke Endowment grant. And the first thing that they wanted us to do, which is something I would like all of you to think about, is to take a poll within your hospital about how many healthcare workers have completed some form of an advance directive or healthcare power of attorney. And what we found was there were very few healthcare workers that had actually done that. And it is really impossible to help a patient complete these directives unless you yourself understand that. So I would like to give a challenge to our audience to check within their facilities and see how they're doing within our own hospital family. But thank you so much for Cassandra. It was a wonderful talk. It's always good to hear from you. This brings us to another subject that is really dear to my heart. I had a sickle cell patient where the hematologist signed off on an incompatible blood transfusion, which made her alloimmunized. It actually dropped her hemoglobin to a 3. So that made it where she could never have a blood transfusion again. The sad part is when she changed hematologists, he told her to lie about her religion. And I told him, no person should ever have to lie about their religion. So Dr. Lewis Sue has devoted so much time to this. He is a professor of pediatric hematology at the University of Illinois in Chicago with a career devoted to sickle cell disease. He earned his medical degree and is also PhD biophysics at the University of Rochester, followed by a pediatric residency at Yale and a fellowship at Children's Hospital of Philadelphia. His clinical and translational research in sickle cell disease has led to over 100 scientific publications, including the landmark STOP study of transfusion to reduce stroke risk. It also deals with pain management of patients. He deals with landmark studies of bone marrow transplantation to cure sickle cell. And he studies and has shared with us the effects of inflammatory vasculopathy due to hemolysis in mouse models. During 25 years in leadership of some of the largest sickle cell programs in the country, he co-authored the Hope and Destiny books for family education on sickle cell. He provides training for community health workers for sickle cell disease and the Sickle Cell Disease Association of America, SCDAA. His experience in applying implementation science includes formal training from the NIH TIDIRC program and sickle cell disease projects funded by NIH for sickle cell in the United States and by the European Union for sickle cell in Africa. He volunteers as Chief Medical Officer at SCDAA since 2020, October 2020, and has been available for pediatric sickle cell case discussions for the National Hospital Liaison Committee since the 1990s. So we thank you so much for your research, and we are so excited to hear your presentation.
Thank you so much for the generous introduction. And thank you for the organizers for inviting me. I'm trying to remember, do I share my screen or are you all gonna do that?
You share it.
Okay. You're going to share your screen, sir.
Sure.
Okay, now you get to see my schedule. Okay. Let's see. All right. How was that? All right, thank you all very much. So this is the title slide. These are my disclosures. I have research in sickle cell, consulting in sickle cell. I'm only going to discuss publicly available information and no specific endorsement of commercial products. I'm just discussing progress.
I'm sorry, Dr. Sue. Can we spend a moment, see if we can change the screen? Because what you're showing us is the speaker's screen. You can stop sharing and then go back to try sharing and then choose a different screen.
Okay. Stop share.
So now share screen and then, okay, still the speaker view. There must be a view there that is for listeners, but if you're finding it challenging, I think James can share your slides for you.
Okay. How's that?
I think you've got it now. James, is it okay?
Yes, very good.
Okay. All right. Okay, so here is where I am. I'm sitting in Chicago, and on a good day, Chicago can look like this. On a not so good day, we have to be prepared for any storms and all that. And so some of the disclosures is that although this is talking about caring for sickle cell patients without blood transfusion, you have to be ready for all kinds of stuff. And so sometimes there are storms and sometimes there might be need for blood transfusion, but our goal is to try to avoid the storms. This is my lovely wife and me in snowshoes when it's minus 10 centigrade, something like that. The objectives today were to look at sickle cell disease as an inherited anemia briefly, just refresher for things that I'm sure everybody knows. Identify the specialist care is helpful for optimal care, and that there are multi-system, multi-organ needs in sickle cell, not just the blood system. And then summarizing how there are new non-transfusion preventive options to reduce the risks of acute anemia and complications in sickle cell. So the classical look at what sickle cell looks like is this kind of picture. This is a photomicrograph that I took under the microscope looking at human blood with sickled forms. You see these elongated pointed cells, as well as the more normal red blood cells under the microscope. And that is the classical understanding, is that it's all about having sickling. What we have been finding from research more recently is that there's a lot of the blood system affected by sickle cell disease, and that white blood cells, platelets, endothelial cells, the clotting system, inflammatory system signals are all involved in sickle cell pathophysiology. If you want to go look at a website with the computer animation of this, rethinkscd.com has that. It's a very cool animation. I'm not going to try to do that now. I'll probably crash my technology. But if you want to take a look at that sometime in your free time, rethinkscd.com. Again, I'm not endorsing a commercial product here, just showing you something cool. But what I'm going to show you is the low-tech version of this. And so let's see if I can expand my head here. So in sickle cell disease, you can also think about the red blood cells with this kind of little model that you have smooth, round, flexible, whereas a sickle red blood cell would be more like this, elongated, pointy, maybe a little bit more stiff, and slightly breaking apart at the ends because of the polymer, the stiff sickle cell hemoglobin making a polymer inside and making this distorted. You can also think about this shape as being kind of like a banana. Now, what does this shape do? Well, one of the things is, if you consider this to be like a blood vessel, this is a pretend blood vessel. I'm in pediatrics, so I do a lot of toys and visual aids. We'll pretend that this is a blood vessel whose job it is to deliver the red blood cell from one end to the other. And to deliver oxygen successfully would be a high-achieving blood vessel. So do you think that this red blood cell will get through the blood vessel? Right? So it can do it with maybe a little bit of pressure, but it slides through pretty easily and successfully got all the way through the blood vessel. However, my sickle red blood cell, pretending with this banana, is going to have a harder time navigating that blood vessel. And kind of, sometimes it can get kind of stuck. And sometimes it makes it through. But there's now additional understanding that with the sickle red blood cell, sometimes it's not just the shape, but sometimes it's also vasoconstriction, that you have tight blood vessel. And so it has no longer the ability, the big lumen that it did. And so that helps to make things get stuck. And so this is blocking the blood vessel, making it not be able to pass through. And so the oxygen is not being delivered and you have a blood vessel that's blocked. This is one part of the pathophysiology, it's just a rigid blockage. Another part, however, is now emerging that there's stickiness, there's adhesion to the red blood cell, shown here as if you put sticky tape on the outside of my smooth red blood cell. And now when it's trying to go through the imaginary blood vessel, it's getting stuck, not because of the shape, but because of the stickiness. And I can drive it through with some difficulty. In fact, I can't even get this guy through until some of the adhesive molecules are stripped off. And even then, it's still not getting all the way through. I'm having a really hard time. So I might have to vasodilate this blood vessel even bigger in order to expand it and be able to get the blood cell through. And then finally, another part of the sickle cell pathophysiology that's being described is that it's not just the shape, but it's also the breakage of red blood cells. So shown here are some dried peppers. People in Nigeria, I know, eat a lot of peppers. Chinese people eat peppers too. These are broken, dried peppers. And so you can see when they break, they release their contents, the pepper seeds, exciting, spicy when you eat them, but also kind of irritating and kind of painful if you have too much of it. Same idea with hemolysis and the red blood cells. If you break a lot of red blood cells, sickle red blood cells or others, when you release the hemoglobin, that is going to set off damage, inflammation, irritation, oxidant stress. And so hemolysis, these broken red cells, is part of the pathophysiology too. And the sickle cell is a hemolytic anemia. So how having hemolysis is part of the condition, but how intense the hemolysis is could be related to maybe how dry this guy is. So if you hydrate the cells better, it may not break as often, or you may be able to have other ways to avoid the hemolysis, reduce the free hemoglobin and inflammation. So those are some of the things shown a little bit in that high-tech video, but that was with some like vegetable examples. Again, because I'm in pediatrics, I just goof around with stuff like that. Sickle cell disease is a global issue where the distribution of sickle cell across the world, sickle gene and sickle cell disease, shown here with the more intense colors, having more individuals with sickle cell disease. So you can see, although there is some in the United States and in Europe, the vast majority of people with sickle cell disease are in sub-Saharan Africa, in India. And so there's global needs for sickle cell care, sickle cell treatments, and sickle cell expertise. In the United States, it's considered a rare disease. Just 1 out of 365 newborns, Black Americans will have sickle cell disease, but in other places, it could be much, much more common, 1 or 2%. In some countries, even 2-3%. So that every classroom would have somebody with sickle cell disease. Every neighborhood, every street might have somebody with sickle cell disease. Hallmark of sickle cell disease is this severe acute pain, shown here by an artist, Hertz Nazaire, who had sickle cell disease and painted this pictures to say, this is what I feel when somebody asks me, what is your pain on a scale of 0 to 10? And I say a 10, this is what 10 feels like, that this is screaming, tears rolling down the face, not able to think about anything else except for the red blood cells. Some of them are red, some of them are blue and deoxygenated in sort of sickled shapes. And then sickle cell disease can affect multiple organ systems, have many symptoms, and need many different specialists. So as we talk about blood transfusion needs and so forth, you might need to be thinking about, will the cardiologist transfuse you? Will the nephrologist transfuse you? The neurologist, as well as the hematologist, because there can be neurologic problems, hematologic problems, bone problems, renal problems, gut problems, gallbladder and kidney, gallbladder and liver and all that. And the organ damage can begin at pretty young ages. So some of the treatments that we're looking at really need to start in pediatrics, even though they may not manifest all the organ issues until adulthood. And until recently, red cell transfusion was the mainstay of treatment for complications of sickle cell. And many individuals with sickle cell received so many transfusions that they developed immune sensitization to the donor antigens. As was mentioned earlier that, having blood that didn't match very well sets off this immune reaction. I remember there was this one patient that our group was taking care of in Atlanta, Georgia, who had so many red cell antibodies that she could not be transfused by anybody in the area. Her only two possible donors were two people in Scotland. And so if she ever needed a blood transfusion, it was from international request. So as if, really couldn't transfuse her. So this would be some of the things. But what I'm very pleased to report is that there are now these different approved therapies for sickle cell disease. I'm going to try to get my head out of the picture here. 4 approved therapies for sickle cell disease in the United States. In different other regions, maybe not everyone has hit regulatory approval yet. But these are the 4 listed here in sort of an infographic format, made by a talented medical student who is from my university, Illinois, Chicago. And it's listing some of the things that might be relevant as people are looking at which treatment to get. So the 4 columns here, the 4 treatments: hydroxyurea, glutamine, voxelotor, and crizanlizumab. And just to break down the different things here and their properties, some of them are for different ages. So younger children, and then Adakveo, crizanlizumab for age 16 and up. Some of them could be taken while pregnant, the glutamine here in the second column. Hydroxyurea is contraindicated while pregnant, and then the voxelotor, crizanlizumab have not particularly been tested for pregnancy, so we can't say. They have different levels of side effects shown here. Some mention of how these medicines are given, so that for the hydroxyurea, for the glutamine, for the voxelotor, these are oral medicines. For the crizanlizumab, it's an IV infusion. And then how will it help? Well, so 3 out of the 4 of them have been shown in clinical trials to decrease pain frequency and also decrease acute chest syndrome for the hydroxyurea and for the glutamine. The crizanlizumab has not particularly been shown to decrease acute chest syndrome. And then the voxelotor, its efficacy is mostly shown in how much it can increase hemoglobin, decreasing hemolysis. And then these medicines can be combined. So hydroxyurea can be given alone, shown with this smiley face here. And that's usually our first line of treatment. But it could be combined, hydroxyurea plus glutamine, hydroxyurea plus voxelotor, hydroxyurea plus crizanlizumab, because they have different mechanisms of action. And so what the hydroxyurea can do is increase the fetal hemoglobin to decrease the polymerization, so less of these rigid rods being formed inside of sickle polymer. It also can make the red blood cells bigger, better hydrated, and decrease some of the hemolysis. What the glutamine does is works against the oxidant stress part of the sickle cell disease. So it helps to keep the red blood cell more in the round shape because it's healthier, less oxidant stress inside. Also fights some of the inflammation and oxidant damage shown with the dried chili peppers and the release of pepper seeds. The voxelotor really is designed to work against the hemolysis. And so it helps reduce the hemolysis. The breakdown of red cells is much slower by binding to hemoglobin and blocking that polymerization also. And then the crizanlizumab has a different mechanism where it's trying to reduce the stickiness, trying to not have as much adhesion molecules interacting between the red blood cell surface and the surface, the endothelial surface of the blood vessel. And so the crizanlizumab is trying to really attack the adhesion mechanism, not so much the shape changes or the oxidant stress. So you can see that there's these different mechanisms now of these 4 different approved therapies for sickle cell disease. And these, glutamine, voxelotor, crizanlizumab just got approved in the last 5 years. The hydroxyurea has been around longer, since about 1998, but the latest formulations that makes it possible for young children to take this has been also just in the last few years. So these are fairly new advances, and we're still trying to get the word out with information like this graphic. And then just to emphasize a little bit more about the details of this. So hydroxyurea can make sickle cell disease course milder. Unfortunately, it does not cure, but makes things milder. Can reduce pain episodes by about half as frequent and not as intense. Reduce hospitalizations by about half. Raising the hemoglobin. Less priapism problems, sickling in the penis. Increasing lifespan has been shown by some data. Fewer absences from school or work is definitely at play. We've had some people say, because of hydroxyurea, I was able to finish my master's degree. I was able to keep my job and not get fired because I was having less absences now. Maintaining IQ is starting to be shown with hydroxyurea. And then because it is long past its patent, in most cases, the hydroxyurea can be manufactured in other places and has been implemented in Africa and in India. Hydroxyurea for the indication of stroke prevention has been extensively tested. So shown here is a meta-analysis by the group shown at the bottom of the screen, Hassan et al. And they showed that with hydroxyurea, it could help to prevent silent stroke, so that having hydroxyurea could be used as an alternative for transfusion for the purpose of silent stroke prevention. Next medicine to mention here is glutamine. So L-glutamine comes manufactured as a powder packet shown here, where one would open 1 or 2 or 3 of these powder packets in the morning, 1, 2, or 3 in the afternoon, depends on the size of the individual. And then this is trying to alleviate oxidant stress, works through the NADH and ADPH type of pathways, reduces pain frequency, markedly reduces acute chest syndrome. And it's basically a food supplement, but it's highly purified to pharmaceutical grade, so we can do it by prescription. The voxelotor, as I mentioned, blocks sickling, reduces hemolysis, can raise hemoglobin by 1 gram, sometimes more. So that I've had some individuals on voxelotor who used to run with their sickle cell disease and hemolysis, their baseline hemoglobin was 8.5 grams per deciliter. With the voxelotor, they were up around 10, 11. Much better endurance, less fatigue, much less jaundice in the eyes too, because the hemolysis was reduced. Not down to 0, but much less. And then crizanlizumab, brand name Adakveo, blocks the adhesion, blocks that stickiness. So this is given as an IV infusion. It's trying to block specifically selectin molecules. And given about once a month, it keeps coating the selectin molecules so they don't interact with the red blood, between the blood cell and the blood vessel wall, so you don't have the stickiness hanging up your blood flow. And this reduces pain frequency. This has been successful for quite a few patients. The ones that I've been treating, I usually have combined this with hydroxyurea. And it has the convenience factor, sort of, that you don't have to remember to take it each day. You just have to come in to the clinic for a once-a-month infusion. So some people like that because they don't want to take a once-a-day medicine. Other people find that to be a big barrier that they have to come into the clinic. I'll just briefly touch on some other alternatives that have been explored. One is artificial oxygen carriers that I believe have been discussed elsewhere during this conference. I can't say they're really great for sickle cell disease, however, because they're short-lived. And the anemia of sickle cell disease, the hemolysis of sickle cell disease is chronic. It's not just for a few hours or days, it's going to keep on going. So although these can be used in sickle cell, it would be really with the idea that it's a temporary bridge for a day or a couple days. And some people have used these on a compassionate use basis for sickle cell emergencies or get through something. I want to mention this medication, eculizumab, is an antibody type of treatment that blocks the hemolysis due to complement. So if you have the complement fixation to the red cell surface as a reason for increased hemolysis, this can be just magically wonderful in blocking that hemolysis. Doesn't fix your sickle cell problems, but there are some people where there's this phenomenon in sickle cell called bystander hemolytic crisis, where the hemolysis accelerates because of complement fixation on top of the usual sickle polymer type of hemolysis. And so you have even more red cell destruction, even more release of broken red cells. But giving the eculizumab has been able to just like halt it, and has made tremendous difference in some people not having to have a transfusion because they could get this eculizumab. It's a manufactured antibody. For the anemia of chronic renal failure in sickle cell disease or pre-op preparation, sometimes erythropoiesis stimulating agents, ESAs, so that would be erythropoietin, darbepoetin, et cetera, can be given to raise the hemoglobin level so that you make a little bit more red cells than you're destroying. But you still have to be careful to not push the hematocrit above 30 because of hyperviscosity issues. And then just to blow through many different options, when one is dealing with a multi-organ condition, there are actually many other non-transfusion therapies that can help a person with sickle cell disease. Antibiotics, vaccinations, fluids. These are all not transfusions, but they can help keep a person out of acute problems. Analgesics, respiratory treatments can all be used in different acute situations or to keep somebody out of the hospital. And then you have more preventive things that are not even medicines: physical therapy, behavioral health, nutrition, school accommodations or work accommodations. We've had some patients where the trigger for their sickle cell pain and hospitalizations was cold exposure. And this one girl was very pleased that she found work as a cashier, but it was inside a supermarket in Chicago where the cashiers are kind of close to the door. And every time the door would open, the winter wind would blow in and all the cashiers were just freezing. So that every time she was on at work for one shift, she would get really cold and often end up in the hospital. One accommodation would be to switch her from cashier to somewhere elsewhere in the store. The other would be to switch her to a different structure of a cashier setup where the cashier was not so close to the door, like up the stairs around the corner a little bit. That's what she eventually did, and she was able to avoid many hospitalizations that way. Some social support can be helpful, complementary and alternative medicine, I'm not going to get into, but there are people who look at those. I think at the same time, I should espouse the idea of complementary medicine so that you take advantage of the things that are FDA approved or otherwise regulatory approved, and not just have the sense that it's either Western medicine or whatever else you're doing. Try to take advantage of both. There are sickle cell centers trying to do even more research. So there's still more medicines in the pipeline of research trying to test them. And there are many watchdog agencies and regulatory requirements and a whole team trying to support the individual on the clinical trial. So here's a picture. It's a center, this young man, teenager, who was participating in a clinical trial. And as he was doing that, all of his data was being looked at by my institution, by a data safety monitoring board, by the Food and Drug Administration, by the Sickle Cell Disease Association of America. as well as by his local team. So this was me when I had more hair, research nurses, father, and then we had, you know, the whole room set up and everything. So that around each individual who's participating in clinical trial, there's a whole support system. And finally, I'll just mention that there are now more and more online resources for sickle cell guidelines to walk you through all these different opportunities, different complications. American Society of Hematology, ASH, has a website and an app called ASH Pocket Guide that puts expert guidelines in your hand or in your cell phone, ASH Pocket Guides. The American College of Emergency Physicians, ACEP, has a website called Point of Care Tools that includes one of the tools is for sickle cell care in the emergency department setting. Other things in this point of care tools are like acute stroke, snake bite, poisoning, so that for the emergency department physician who's very, very busy, may not have time to look up every single thing or find every single app, this consolidates things in one place, and it has evidence-based guidelines, very, very recent, just in the past 2 years. The Society of Hospital Medicine has also got guidelines and online modules, also developed 2021. People were busy during the pandemic putting stuff like this up. This is for in the hospital patient. You know, they've already gone past the emergency department. And I'll slightly toot my own horn here. So with several students, we wrote a recent paper that just got published last month, Managing Sickle Cell Disease in Patients for Whom Blood Transfusion is Not an Option, highly similar to this talk. So our objectives were to talk about caring for sickle cell patients without blood transfusion, that this is something that's worldwide, and by reducing the storms of acute illness, trying to prevent things from getting to be so bad that you get hospitalized, you might avoid transfusion. But it probably will take having some specialist care, probably taking some non-transfusion preventive medicines, or being very, very, very diligent about behavioral choices, accommodations at school and work. And I'll leave this one up for the last slide in case people want links to some of the things that I mentioned, and also put in a plug for Sickle Cell Disease Association America's website and One SCD Voice, which is a platform that has more information yet about sickle cell. And let me see what kind of Q&A we have here. The basics difference between somebody with sickle cell disease and the sickle cell carrier? Oh, that's a great question. So the basic difference is that in sickle trait, that person would have just one gene for sickle hemoglobin. The other gene would have normal hemoglobin. And this makes it very, very difficult for the polymerization to occur, for the sickle form to show up, makes there be much, much less hemolysis. And so for the most part, people with sickle trait are normal and have normal life expectancy, don't have organ damage, don't have very many hospitalizations, or pretty much live normal life and can go their entire life without ever even knowing that they had any sickle gene. The biggest medical significance of that would be that they can pass along that gene to their offspring. Under extreme conditions, and I want to say really extreme, somebody with sickle trait could develop sickling, but it would be with like dehydration plus exhaustion, or working yourself extremely, extremely hard in a physical workout, like attempting to lift 200 pounds when you're not really in shape for that, or trying to do 150 pounds 40 times because you're trying to work out in one day, which you should have been doing in a month, or doing military basic training, or doing American high school football practice in August in hot climate in full uniform when you're out of shape. So, or going skiing in a cold environment, high altitude, plus drinking alcohol and dehydrated and out of shape. So it's when you put together all these bad factors, that's when somebody with sickle trait might get a problem. But if you mitigate any one of those, so particularly if you're in shape, in good physical condition before you attempt to do something that's extreme sport, then you should be okay. Or if you hydrate well, you should be okay. And so there are methods now where the US military has developed different training methods trying to avoid causing problems for people with sickle trait. Mostly involves hydration, but also means that when you start the exercise in basic training, you start with a regular shorts type of uniform instead of the full everything, long sleeve, long pants, and a 50-pound backpack when you're really not in shape and it's too hot, because you don't want to kill your military recruits. That's not good for your military. You kill all the recruits. Next question, what point do we say sickle cell will critically or necessarily replete blood, and what happens if he or she is a Jehovah's Witness? Well, that's a case-by-case situation. I'm in pediatrics, and so we do have some situations where a child with acute chest syndrome may be facing going on a ventilator or having acute stroke. And those would be situations where I would think that this child does need to have a red cell transfusion to save their life or to avert the stroke or to keep things from getting worse. And in the United States, we would then ask for a court order. There are other points where transfusion is not critically necessary, and it's a matter of judgment. And some of the guidelines that are listed in here actually say try not to transfuse in many, many cases because you don't have to. So it's a very judgment call kind of thing. Next question. Ugari Gab is very busy. Any genetic solutions, genomic therapies? Yes, there are. Beyond the scope of this talk, sorry. I'll give you another talk. Actually, I'm doing one later today, but we could talk about that in the future. And cutoff for the use of hydroxyurea. So hydroxyurea can be offered from the age of 9 months. There's no particular upper limit for the age for the use of hydroxyurea. It's contraindicated in pregnancy because there's theoretical chance of birth defects shown in laboratory mice. So far, birth defects have not been seen in people. Possibly there are some places where the obstetrician, in consultation with the hematologist, would halt the hydroxyurea during part of the pregnancy and maybe resume in the 3rd trimester. Because a lot of times a woman who had been doing well on hydroxyurea stopped it to become pregnant, started to have more sickle cell problems. And so getting through the period of rapid fetal development and then maybe resuming the hydroxyurea in 3rd trimester has been considered by some people. This is not medical advice from me. This would need to be case by case and would definitely be in consultation with the obstetrician and the hematologist for that particular person. Let's see. Is there something else in the chat? Oops, I'm sorry. Dr. Yvette Funch was supposed to handle the Q&A. Was there anything else I missed?
No, that was wonderful because you were addressing the particular good questions that related to sickle cell. We do have some other question and answers, and I think that this part goes to Dr. Kawamoto, and we can all work together. We only have about another 6 minutes to answer some of these questions, so I'll turn it over to her.
Thank you very much, Professor Xu, for your excellent and educational talk. And yes, all of us are reminded of how such a great feat it is to treat one of the most intractable bloodstream disease, sickle cell anemia, without use of the transfusion. And you, yes, are also kind enough for all of us to, come to grip with the pathophysiology of sickle cell anemia in a very understanding way by using the tools. And that also reminds us that how the normal blood cell can contribute to our microcirculation normal condition by giving and exchange the important message between the endothelial cells. And so thank you very much for your diligent and work. And so we all congratulate your the job. Thank you very much, everyone. And so we had a very nice three lecture today. And so, Yvette, is there any question you would like to ask other speakers?
Yes, please. I see that Gary Conan, who was one of our speakers yesterday, has his hand up. You want to go ahead, Gary, and ask your question?
Mm-hmm. I'm sorry, Yvette. That was an accident. I'm sorry.
That's okay. There was one question that I saw that asked Cassandra if they could get a copy of the healthcare power of attorney that she presented on her slide presentation that was directed for Jehovah's Witnesses. That slide itself may be helpful for you, but at least in the United States, every state has a specific state healthcare power of attorney. Now, Nikki Haley in South Carolina signed, as did many states, a form to where these directives would be uniform. But you can get those from any hospital or online. There are a couple of states that are a bit different, but it might help you to become familiar and realize that these healthcare power of attorneys are not just addressing blood transfusions, it's patient choice. It's letting medical professionals know what they might be allergic to in an emergency. And it also discusses end-of-life decisions, and people should give consideration if they would like to be an organ donor. So I hope that that helps answer the question. There are so many good questions, and we only have about 4 more minutes. Dr. Kumamoto, there was a good question about should you give oxygen with low hemoglobin if they are maintaining their oxygen saturation? This is an excellent question because I saw a change with some of our young critical intensivists to where they were not giving oxygen. So could you speak briefly on that?
Are you asking me? Or?
I thought you might speak better than I could on that.
All right.
Or another panelist.
Yes. Why not ask the panelists we have today, and Dr. Daniel Otokpa and Dr. Arvin Gross and Shannon Farmer and Marissa Smith. Is there any comment about the question that Yvette just now asking?
So, Yvette, could you repeat the question, please?
The question was, in the presence of anemia, and the patient is maintaining their own oxygenation, and where I assumed that it was low anemia, because my case was a hemoglobin of 5. They were maintaining their oxygen saturation. The question was, should oxygen supplementation be given?
Okay, from my own point of view and in my own practice, the answer is yes. If a patient is having acute anemia, for instance, and the bloodless patients would maintain their saturation. They could even have 100%. And the hemoglobin is maybe 4, and they just had surgery. The hemoglobin is down. So it is the number 3 pillar for bloodless surgery that you must optimize the tissue oxygenation. So to keep it that way and give the body time to recover, we do administer oxygen, perhaps 24 hours, even though the patient is fine. The patient will say, I'm okay, I don't have a problem. There's another situation where some patient had menorrhagia and bled down to hemoglobin of 1.1. And she seemed okay, but she had to be on oxygen until her body is perfectly okay.
I agree with that. You want to give, the body is wonderful. It will try to compensate, but it's making it work harder. So what you're saying is you're giving the body a time to rest and recover.
And also I second that, because although our hemoglobin has a limitation of carrying the oxygen, I mean, if you illustrate the hemoglobin as some truck, so the truck can have a limitation of carrying the luggage. But the high dose oxygen can go into the circulation and raise the level of reserve oxygen. Yeah. So although the saturation point of the red cell carrying ability has a limitation, but high dose oxygen can make the reserved oxygen in the circulation to go into the peripheral every tissue. So I think it makes sense to raise the level of oxygen inhalation.
Thank you so much. We are at our time limit. There are many, many more great questions. If we did not get to you, feel free to contact us by email. We want to make sure that everyone is given attention and your questions are answered. We are now going to segue into our industry presentations. And, this is an international audience. So now we're going to travel to the Netherlands with a unique product called HemoClear. And Dion Asemwege, I'm sorry if I butchered your name, is the Global Business Development Manager. And this can be a true game changer, especially in developing countries. So we look forward to your discussion, Dion.
Thank you very much, Yvette, and thank you very much for having me again. It's always a pleasure to see all of you, and welcome to the Netherlands, I should say. I'll go ahead and share my screen. Am I on full screen?
I think you need to share your slideshow.
It's not working with me. Try again. Yeah.
Yeah.
Perfect. So again, thank you very much for having me. It's always a pleasure, and I'm excited to talk to you today a little bit about what's been going on with us since the last conference that we had in November. The topic of today is how do we as HemoClear with our microfiltration technology try to support patient blood management in the obstetric setting. I think all of you could very well and better than I can explain the importance, the relevance of patient blood management or bloodless management, bloodless surgery, however you'd like to call it. And when you think about patient blood management, in the back of your head or the front of your head is cell recovery also. We all know that before any cells can be recovered, they're ideally undone from any contaminants that you ideally don't give back to the patient. And we know the gold standard technology, the centrifugal technology that does this very effectively, captures the red cells, but unfortunately there's also some downsides. This is costly, complex equipment that requires a trained operator and therefore isn't always available and limited to those settings where the operator's there, the predictability of the bleeding is high enough. But that makes that the lack of simple and affordable cell recovery technology is a limiting factor in using high quality autologous blood and therefore in patient blood management worldwide. We've come in with a solution to this problem by the first microfiltration cell recovery device. And this is a device that can be used in a simple filter procedure that doesn't require any additional equipment. It produces high quality washed blood cells. And as a bonus, you also get the platelets with the red cells. I specifically say microfiltration because the thing that distinguishes the HemoClear microfiltration technology from other existing filters is the 2 to 3 micron pores that are very specific for the blood cells that you want to capture, the platelets and the red cells, where because the pores are small enough to get rid of all the non-cellular contaminants, the proteins, the ions, the microaggregate, a high quality blood product can be produced that supports safe and effective cell recovery. This is obviously a marketing representation of the true procedure, but in a nutshell, because in the essence, it doesn't take much more. The blood is collected like you're used to with a centrifugal device in a sterile manner. Then in order to start processing, in our case, filtration, the blood bag is simply hung above the filter device. It runs down on gravity. And in a simple 30-minute procedure, you get to step 3 where you can give back washed, platelet-rich, high-quality blood cells to the same patient. I today zoom in on obstetrics because as some of the, or a lot of leading physicians have published about and very well explained, there's still a lot to gain in terms of patient blood management in the obstetric setting. We all know that the blood use in the obstetric setting is relatively high, sometimes up to 40% in some departments. Postpartum hemorrhage and anemia in pregnancy remain high and great issues that need to be addressed. And we recognize that microfiltration could boost this autologous blood use specifically in this setting and have the clinical added value gained for patient blood management in the obstetric setting. If it were easy, I think you've done it decades ago. In the recognition that there's a high clinical value, we also think about what are the potential hurdles and what does it take to support microfiltration, to have microfiltration support patient blood management in obstetrics. And there's first, top of mind, the clinical requirements, of course, but also looking at the health system, which the group in Calabar shed quite some light on with the research project. But also in terms of implementation and clinical guidelines, there's requirements that need to be met before we can actually start supporting. I do start with safety, safety first, as they say. It's a very important one. And in the obstetric setting, the safety considerations are the amniotic fluid, the fetal red cells, bacterial contamination, etc. So to first gather some evidence on the safety, we collected data in a trial where in cesarean sections, blood was lost, and this was caught and split in 2 volumes. One was processed by the gold standard centrifugal device, and then the other was processed by HemoClear. And by doing blood quality analysis before and after processing, we could compare what the quality standard was. This is a snippet of the results, just to give you a flavor of it. The alpha-fetoprotein was measured as a marker for amniotic fluid. And as you see, it's high relatively in the shed blood. But after processing with either HemoClear or the centrifugal cell saver, it was lowered to a comparable level for both devices. Then in terms of fetal red cells, they were both concentrated, which made sense, as both devices concentrate red cells. And here the same recommendation of giving anti-D prophylaxis when needed, when there's a risk of alloimmunization, would apply to both HemoClear as the cell saver, as it already does. The same goes for heparin. It's comparable to the amniotic fluid finding. HemoClear also reduces the anticoagulant like a centrifugal device. That said, on to the next step, so to say. Since we've had these results, we're looking to make the next step and planning to make the next step by investigating further the safety, but also diving into clinical cost effectiveness and looking at how this can best be implemented under the guidance of leaders in the field, of course. This will be a multi-center setup, and as we speak, the partners are selected, the protocols finalized. So I'd be very keen and looking forward very much to keep you updated, and I'm hopeful that in November, in the next meeting, I can tell you more about this. That's my talk for today. Thanks again. Thank you very much. And if there's any questions, I'll be happy to answer them.
Thank you so much for your clear presentation. I have a question. I didn't see any other questions, so I'm going to ask one. I'm used to standard cell salvage devices. I'm unclear, since I haven't seen this in action, how does it actually wash the cells? I can understand the gravity and the microfiltration, but how does it actually wash the cells with saline solution?
Excellent question. So before it runs through the filter, the washing solution, isotonic saline, as with a centrifugal device, is added in a 1-to-1 ratio to the blood volume, briefly mixed, and then it runs through the filter. And by getting rid of part of that saline in the filtration again, you effectively washed.
Thank you so much.
You're very welcome.
I am not seeing any more questions concerning it. It was a beautiful presentation.
Yvette.
Sorry, I see Gary's hand up. I think this time it's for real.
Yes, for real this time, Yvette.
Okay, Gary.
Thank you. Thank you so much for your presentation. It's always interesting and exciting to see new technology come out that can be implemented in the OR. And I appreciate the work there. I have a few questions for you. So number one, on your Cell Saver versus your microfiltration system. Can you share which Cell Saver you used and if you used a leukocyte reduction filter with the blood being processed?
Yes, I'm going to do it by heart. I think it was I'm sure it was the Cell Saver from Haemonetics. The thing I'm doing by heart is the model. So I think it was the 5, but I'll have to double check.
Okay.
And then in this scenario that I showed you, the results, this was a first look at the safety. So there was no reinfusion of blood and no use of a leukocyte depletion filter.
Okay. One more question. So let's say you collect, let's say we're in OB and we collect 500 mLs of shed blood. From the point of collection to microfiltration to being reinfused back into the patient, how long or how much time does that take?
So to process the 500 ml, that's depending on the hematocrit, but rule of thumb about 30 minutes. And then I don't include collection and reinfusion with that because that's the same as with the Cell Saver. So depending on the bleeding time, etc. I hope that makes sense.
It does. And one last question. I'm sorry, I may have missed this, and I know you're looking at or you're getting ready to do more studies. So is this being used anywhere in the United States right now?
No, our FDA approval is pending, so it's not in the United States yet.
Okay. Thank you so much for your time. I really appreciate it. Thank you.
Thank you for your questions.
Diana, I think Dr. Spies, is he part of that attempt at approval?
Yes, Bruce? Yes, that's correct. He also gathered some data, and it's under review. It takes a little longer than we would like, but we're working on it. Correct.
I see Dr. Sue's hand is up. Do you have a question?
Yes, if I may. What arrangement do you have for oxygenation? Is it just going to be whatever oxygen level was in the bag, or is it permeable to air?
So oxygenation of the produced blood product, you mean?
Of the blood that's being held in the bag for half an hour or something like that.
While processing, yes. I'm thinking if I understand your question correct, but you might know from my answer. So I'm just going to answer, and then you let me know if I address the question correctly. So the blood bags are standard blood reinfusion bags. I would have to dig up in terms of oxygenation what goes through and what's permeable. But there's no rules or protocol that we apply specifically for oxygenation.
Okay, thank you.
But again, those are fresh red cells, so they do not have storage lesions on them, so they will be able to, once they're in the patient, oxygenate better. Any other questions? We're going to move on then to another industry presentation, and we're now going back to Nigeria with Blessing and Isir Iran. I'm sorry. So it will be Blessing. But he is he's a team supervisor with Innotech in Nigeria. He will be speaking on optimal therapeutic management of IDA using ferrous gluconate, copper, and manganese, a unique formula.
Thank you, Yvette. Good afternoon, clinicians. I hope I'm being heard. Okay. So thank you for this wonderful opportunity to be able to deliver an industry presentation at such a phenomenal platform, such as the BMS. I'm representing Innotech International, which is a 100% subsidiary of Innoterra Groups worldwide. The Innoterra Group was founded in the year 1913 by René Chanteroux, a pharmacist, and as of today, it's been managed by Arnold Kobe. Innoterra is also the 5th largest pharmaceutical group that's independent worldwide. So we have over 20 products in our portfolio, but today our key focus in Nigeria are 4 products, namely Totema, Polygynax, Flebodia, and Agios. And we have 2 authorized distributors in Nigeria, namely Arsenal Laborex and Chief Pharmaceuticals. So for the purpose of my presentation today, I'll be taking us on the optimal therapeutic management of iron deficiency anemia using ferrous gluconate, copper, and manganese, which is a unique formula. So for starters, I like to define iron deficiency anemia. So it's actually a chronic form of anemia of insidious cause caused by iron deficiency, which causes a reduction in oxygen carrying capacity of the blood. And some of the etiologies include insufficient dietary intake, especially in this part of the world, Africa, Nigeria. The diets that we eat is largely rich in carbohydrates, rarely rich in iron sources. So that's one area where iron deficiency anemia can arise from. There's increased need in terms of growth and pregnancy, increased demand because of the fetus, and of course, some intestinal diseases as well. Also, we have excessive output and losses, which can be observed from significant bleeding from wound, surgery, menometorrhagia in the case of prolonged heavy intrauterine bleeding, and parasitic infestation such as hookworm infestation. Also, we have some urinary elimination and fecal elimination. All of these come together can cause iron deficiency anemia. Also, looking at preoperative anemia, we have some origins of anemia, namely, we can have anemia as a result of some medications used, like in the treatment of diabetes, for instance. We know metformin can cause a reduction in hemoglobin levels. We know that proton pump inhibitors can inhibit ferroportin, which causes a reduction in iron absorption. And this happens because there's an upregulation of hepcidin. Blood loss as well, like iatrogenic origin caused by repeated phlebotomy for diagnostic purposes, bleeding from genital origin or gastrointestinal origin, hemolysis, and of course, congestive heart failure, which can result in hemodilution and anemia. And of course, inflammation, which can be caused as a result of activation of the immune system due to underlying conditions, and some inflammatory cytokines like the alpha tumor necrosis factor, interferons, interleukin 6, 8, and 10. We'll see some renal reduction in erythropoietin production and reduced resistance of erythropoietin to severity of anemia. Anemia definitely doesn't start out as anemia. It starts out as iron deficiency, and then the iron stores ferritin are depleted, and then eventually you have anemia. If you check an iron deficient patient, the hemoglobin levels will appear fine because it's been maintained at the expense of ferritin. But subsequently, once the iron stores are depleted, then you see that oxygen delivery will be truncated as well, and hemoglobin levels will be critical. I want to go on to classify the stages of anemia. The first stage is usually characterized by decreased iron stores, less ferritin levels less than 12 milligram per liter. Then there's a deficit of erythropoiesis, and you have increased transferrin, decreased iron saturation, and of course, microcytic hypochromic anemia. I'll briefly then go into some of the signs and symptoms of iron deficiency anemia, which we're quite familiar with. In iron deficiency anemia, you find patients being often lethargic. There's general body weakness. They are overexcited easily. There might be dyspnea. Then you can have polypnea and also tachycardia. And some of them have weird food cravings. Some crave ice, and you have some skin and inflammatory disorders. So there's glossitis, there's cone-shaped nails, for example, and of course, reduced hemoglobin levels. And when you observe red blood cells in a blood smear test, you see that they will appear pale and small in size. So just as a reminder, when you're diagnosing anemia, these are some of the values to look out for. Men, once their hemoglobin levels are less than 13 grams per GL, according to WHO, then they are anemic. For pregnant women, once they have hemoglobin levels less than 11 grams per day, they can be classified as anemic. Then for women of childbearing age, less than 12 grams per day is the number to look out for. So what is the assessment? As a matter of fact, 1 in 3 people are affected by anemia globally. It happens in developing countries as well as developed countries. In developing countries, the reason is mostly nutritional, while in developed countries, the reason is multifactorial. So out of 1 in 3 people who have anemia, 50% of these people are anemic as a result of iron deficiency. So anemia, bringing it back home now, is a public health problem in Nigeria. Over 10 in 10 preschool age children are affected by anemia. Almost 6 in 10 pregnant women as well are affected, and almost 5 in 10 women of childbearing age are also affected by anemia. So these are the population at risk for anemia. And we already know that in pregnancy, anemia is one of the leading causes of maternal deaths in Nigeria. Anemia has an impact on newborns. You know, you have your intrauterine growth disturbances. There could be disturbances in cognitive abilities and also increased susceptibility to infection. In surgery, anemia is able to increase the risk of mortality by 5 times. And also it doubles the morbidity rate. As a matter of fact, the reference treatment for iron deficiency anemia is oral route. Okay, so I just want to quickly go into some data from literature. According to a prospective study that was conducted in 2014 in 28 countries, we're able to see here that preoperative anemia increases the mortality rates and ICU admission rates significantly. Still looking at the prevalent data, we can see that 50% of patients who undergo a gynecological surgery or vascular surgery worldwide are affected by anemia. So it's something that's a cause for concern. Then these are data from Africa as a whole, not just anemia. We can also see that the figures are quite similar. So this means that iron supplementation is mandatory. So now when we're looking at iron supplementation, we're going to look at together some of the iron replacement strategies. But the first thing, of course, is to identify the etiology, and then you can address accordingly. So in the case of iron deficiency anemia, perhaps depending on severity of anemia, you may want to give dietary iron, oral iron, parental iron, or blood transfusion. Blood transfusion should not be used as a treatment for iron deficiency unless the individual has severe anemia or hemodynamic stability. So patients with severe anemia or who have life-threatening anemia may be treated with red blood cell transfusion. But thankfully, this entire week is dedicated to ways in which patients can be treated without the need for red blood cell transfusion. So, and it will be better to tilt towards more of that. This data also shows that lowering the transfusion threshold of to 7 to 8 grams per day versus 9 to 10 does not change the mortality rate at 30 days. So this means that there's really no need for liberal transfusion. And as a matter of fact, maybe there's no need for any transfusion at all. So since we have said iron supplementation is mandatory, we're now going to look at some of the therapeutic targets, which is better for your patients, ferrous or ferric. As a matter of fact, we know that for proximal intestinal absorption to happen, iron has to be in the ferrous form. So if you have a ferrous form of iron, then it's readily available for proximal intestinal absorption. Then the WHO, as well as British Society of Hematology, recommend the use of ferrous form of iron. Also, what targets would you prefer for your patient, liquid or solid form of iron? Liquid form of iron definitely allows optimal product distribution because the product is spread across the proximal intestinal surface. Absorption is enhanced, and of course, there's reduced GIT disturbances. The British Society of Gastroenterology also recommends that ferrous gluconate is better compared to ferrous sulfate in terms of tolerance. Now, looking at the tablet and ampoule format as well. Ampoule format also ensures that there's a quality of your formula at every time. Also, compared to bottle preparation, when you open and close, over time, the content might be oxidized, but in an ampoule format, it's always available. So what is the Inotech solution? The Inotech solution, when it comes to treating iron deficiency anemia, is Totema. So Totema is a unique formula of 50 milligrams of ferrous gluconate, iron, manganese gluconate, and copper. And Totema is indicated in the curative treatment of iron deficiency anemia in adults and infants, and also preventive and curative treatment of iron deficiency. So we're going to look at together why Totema has such a unique formula. We have seen cases where hemoglobin levels with Totema use has been raised by 3 to 4 grams per DL in as early as 10 days. PCV has been raised by 6 to 10% in as early as 10 days. Why does this happen? It's possible because the active ingredient in Totema is able to act at all steps of iron metabolism. So we covered that it has ferrous, so it's readily available for proximal intestinal absorption, unlike ferric that has to be reduced to ferrous. So when you have more copper in the cell, more iron is absorbed. Also, copper ensures mobilization of iron from the hepatic stores. It works with a copper-dependent enzyme, ceruloplasmin, as we already know, which catalyzes the oxidation of ferrous back to ferric. Another thing that copper does is also the fact that it ensures the binding of iron. In this case, it ensures the oxidation of ferrous back to ferric because it's in ferric form that iron will be transported. So after iron efflux has occurred through the aid of ferroportin, ferrous has to be oxidized back to ferric, and hephaestin will catalyze that, and it's also another copper-dependent enzyme. One more thing that copper does is that copper stimulates hematopoiesis by ensuring the maturation of hematopoietic cells. Lastly, manganese, which is an active ingredient in Totema. Manganese is a cofactor for the activation of enzyme systems for hemoglobin synthesis. Then it also plays a role as an antioxidant. So as clinicians, when treating anemia, we're probably looking for something, a medication that is fast acting, that is able to increase the hemoglobin level, restore ferritin, well tolerated, and has a good compliance. Does Totema meet all these criteria? We're going to look at it together. From studies that we have, Totema actually is quickly absorbed. As a matter of fact, as early as 24 hours, there's a plus 21% rise in the group with Totema. And then as early as 72 hours as well, we have a plus 44% rise in serum iron. So it means that Totema is rapidly absorbed. Beyond being absorbed, how about the clinical improvements in terms of hemoglobin? By day 30, Totema is able to normalize the hemoglobin levels of across all age groups, adults, pregnant women, and children. Beyond normalizing hemoglobin, Totema is also able to replenish the iron stores in almost 90 days in the groups of people who have been exposed to Totema. Totema is also very well tolerated. And Totema is ferrous gluconate. And we already know that the British Society of Gastroenterology endorses this form of iron salt. Totema has an adjustable iron dose in ampoules. And we have over 70 years of experience in treatment of iron deficiency and anemia with Totema. Totema is registered in over 60 countries worldwide. In terms of compliance, Totema is very good as well. In this study conducted in pregnant patients, we can see that the Totema group had no patients withdraw from the study due to adverse events. But to my extreme right, you can see that the group that had the protein succinylate liquid ferric had patients dropping out of the study due to side effects. So in the case of Totema, you have high compliance, the treatment is completed, and the patient is treated. This is the mode of administration of Totema. It comes as oral solution in ampoules. Each box contains 20 ampoules, and they are scored at both ends. So the patient just has to hold the ampoule firmly at one end, snap, then invert it over a little quantity of water, and then break the other end, and then the patient can drink it. It can be mixed with water. It can also be mixed with orange juice, either way. But patients should avoid taking it with magnesium, calcium, or aluminum salt to avoid chelation or reduction of absorption. Totema also has a flexible dosing. For prophylaxis, you do 50 milligram elemental iron daily, which translates to 1 ampoule. For mild to moderate anemia, 1 BD. And for severe anemia, you can do 2 ampoules BD to 4 ampoules BD. So the maximum is 2 ampoules BD or 1 ampoule TDS. So the maximum is 4 ampoules daily. So we usually get this question a lot. Why is Totema in an ampoule format? Totema is in an ampoule format for better bioavailability, and also it delivers the exact amount of iron needed. Totema comes at 200 naira per ampoule in Nigeria. And as a summary that I've already covered, Totema is a fast-acting drug, normalizes HP, effectively restores iron stores, very well tolerated, and is a unique formula. Thank you very much. These are my references. If you need them later. Thank you for listening.
Oh, thank you, Blessing. I think we have a couple of questions for you. We're running a little bit short of time.
Okay.
If someone asks, can this be combined with other hemanetics like ferrous tablet?
Okay, thank you. When you are giving your patient Totema, you don't need to combine it with any form of iron supplements again orally. Even intravenous is not advisable. So if you are giving Totema, you give Totema. What you can do is, if you need a higher dose, you can increase the number of ampoules. So if you want 100 milligram elemental iron, you can do 2 ampoules. If you want 200 milligram elemental iron, you can do 4 ampoules. But you don't need to give it alongside any other form of oral iron supplement. Thank you.
There's one more question about these ampoules. How does that compare to IV iron in raising the hemoglobin? I think with that question, cost factor might want to be worked in with that too. Could you please enlighten us on that? Okay, thank you. Yeah, Totema in terms of efficacy is comparable with IV, but without the drastic side effects. So, like I said, in several hospitals in Nigeria where hands-on experiences have been, done with Totema, we've seen, as long as the etiology is iron deficiency anemia or anemia due to blood loss, we've seen cases where somebody's hemoglobin level has moved by, has gained 3 to 4 grams per DL in as early as 10 days. Then PCV has gained between 6 to 10%. So it works really, really fast for an iron supplement. So if you need to give someone iron and you give Totema, you're very, very okay compared to IV. It works just as fast. There's not so much difference. Thank you so much. Beautiful presentation. Well, we're coming to an end of the day. So Dr. Kawamoto, would you like to have a few comments? Can you unmute yourself?
I'm so sorry. Thank you, Yvette. And yes, we all agree that we had a very intriguing and informative lecture today, and having excellent speakers, including 3 speakers on the keynote lecture and 2 speakers from industrial presentation. Now, yes, I would like to ask Yvette to preview or introduce the next day's program for all of us. Could you do that? Yes, I'm happy to. This was an exciting day, and tomorrow is also going to be very exciting. It starts out with something very near and dear to my heart, as I ran a cell saver throughout South Carolina and North Carolina. And I thought I understood it until I worked with Gary Conan and met Jonathan Waters. And Jonathan Waters will be giving the keynote address tomorrow. He is one of the most researched physicians in this area. Kind heart, very easy to approach with questions, even though I know I've been a pain in his neck. But he will be giving the keynote address, Blood Salvage and Bloodless Surgery, More Nuts and Bolts. Again, we'll have question and answers, and then a panel discussion with some of the leading world experts. So if we didn't get to your questions today, tomorrow will be a great opportunity to present it. Would also like to especially thank all of our presenters. A lot of work goes into this. However, none of this could be accomplished without teamwork. There has been so many volunteers that have graciously donated their time, their effort, their blood, and their sweat.
And truly, it shows if we're going to bring this to a worldwide standard, like aviation has reached Lean Six Sigma, the highest safety level, it's going to take a teamwork. It's not, aircraft flying is not just dependent on the pilot. It's not just the captain. It's not the first officer. It's not just the crew members. You've got maintenance. You've got ground control. It is totally a team effort. So I thank everyone for being in attendance. I hope this message will go worldwide and hope to see you all tomorrow. Thank you so much. Have a great day.
Thank you very much. Thank you very much for nicely introducing for next days. Yes, just looking over the program is how exciting it is to have that. Yeah, thank you very much. So we call it today for today's meeting. Thank you very much for participating in this today's meeting. Thank you.